My name is Melissa Chavez, and I'd like to welcome everybody. On behalf of Glaukos and the Optometric Cornea, Cataract, and Refractive Society, or OCCRS, we'd like to thank you for joining us and welcome you to the co-management of the Keratoconus patient webinar by Dr. Jack Parker and Dr. Mitch Ibach. We have an insightful talk ahead of us and want to ensure your questions are answered. So we have enabled the Q&A function, which can be found at the bottom of your Zoom screen. Please feel free to submit your questions at any time, and the speakers will aim to answer them at the end of the program. As we're using the Q&A function, we have chosen to disable the chat function so that questions go directly to the speakers. In summary, please use the Q&A function and not the chat function to submit your questions. Also, this webinar is being recorded so that we can make this information more accessible. We will be sending a link of this recorded webinar out to all registrants within 1 week, in addition to a survey, so that Glaukos can continue to be a valuable resource and provide adequate support to you and your practice. Please take a moment to respond. I'm pleased to introduce the speakers of this collaborative discussion. Joining us today are Dr. Jack Parker and Dr. Mitch Ibach. Dr. Jack Parker is a refractive surgeon at Parker Cornea in Birmingham, Alabama, and is considered one of the world's foremost authorities on the treatment of keratoconus and Fuchs dystrophy. Parker Cornea participated in the Avedro FDA clinical trial for the treatment of keratoconus with corneal cross-linking and is the first provider of FDA-approved corneal cross-linking in the state of Alabama. Dr. Mitch Ibach is an optometrist at Vance Thompson Vision in Sioux Falls, South Dakota. He specializes in anterior segment surgical care, including cataracts, corneal diseases, glaucoma, and refractive surgeries. Dr. Ibach has years of experience in the diagnosis of keratoconus and corneal ectasia following refractive surgery, as well as a sub-investigator in Avedro's FDA clinical trials. So without further ado, I'd like to turn it over to Dr. Ibach.
Thank you, Melissa. First off, thanks to Glaukos and OCCRS for providing a platform for us to meet tonight, albeit virtually, to really discuss keratoconus and corneal cross-linking for our patients. Hopefully this next hour provides everyone that's tuning in with a break, a little bit of normalcy from everything that's happening in our world right now. Hopefully we can interact with friends and colleagues, have a question and answer type discussion, hone our craft as eye care providers, and really come back after this pandemic stronger for our patients. I want to give kudos to all of you. We're trending over 200 participants. And you know, the biblical phrase, iron sharpens iron, I think applies here. And so thanks for jumping on to learn about cross-linking for your patients. I'm privileged to be joined by Dr. Jack Parker tonight from Parker Cornea. We have almost, we're going to trend up to about 250 to 300 participants, Jack. So we got to up our game tonight. But I want to start with kind of the quick story about how I first met Dr. Parker. I had the opportunity to lecture this past March in Atlanta for the SECO meeting, and I was just getting ready for my second lecture. I was standing up at the podium, plugging in my slides for a talk on an update on corneal surgeries. And one of the attendees came up to me and said, "Hey, did you catch Dr. Jack Parker's lecture this morning on innovations in corneal surgery?" And I said, "No, unfortunately I had a conflicting lecture, so I didn't make it." And he said, "It was the single best lecture that I've ever been to." And due to time constraints, I had to then pause this conversation and try to jump in and give my lecture. So I gave a 1-hour lecture. The whole time in the back of my head, I'm wondering, what was so good about that lecture? And so afterwards, I sought this gentleman out, and this is an optometrist from a well-known in our country optometry ophthalmology co-management practice. And so I went up to him kind of seeking a compliment after my lecture, and he did not say, "Your lecture is now the single best lecture I've ever been to." And so I wanted to pull on the string a little bit to see what was so good about Dr. Parker's lecture. And he said, well, 2 things. Number 1, he's a great storyteller. And number 2, he had the ability to make complex corneal surgeries simple. And so this kind of aligns with the Einstein principle of it's really easy to make a simple problem complex, but it's really complex to make a problem simple. And so hopefully with that, we'll jump into things. And after this, you can say, this is the single best webinar that I've ever been to. That's kind of Dr. Jack Parker's history. And so before we jump into some of the questions that have been posed to us, first, just what is the FDA approved technologies? What's the indication and label say for cross-linking? Well, there's really three things that are approved by the FDA for cross-linking in the United States. First is Photrexa viscus. This is riboflavin. It's a riboflavin that has a near neutral compared to our tear film osmolarity, and so it doesn't push or pull water. Second, we have a riboflavin that is hypotonic with Photrexa. Intraoperatively, if we need to swell the cornea, thicken the pachymetry, we can. And then the third is the KXL light delivery system, delivering ultraviolet A frequency light. For safety information here, we're going to cover this more in depth, but an important note is currently cross-linking should not be performed on label for pregnant women. This was exclusionary in the FDA clinical trial. So let's go into our first question here. We're going to kind of bounce questions back and forth. So first to Dr. Parker. Jack, what do you use for the diagnosis of keratoconus? What are some of the tools in your tool bag?
Well, first, I just want to say thank you for such a sweet and very, very nice few words of introduction, Mitch. I mean, you're such a kind guy. And I have to say, you know, it really is always so nice to get to work with you because you really are such a take charge, you know, leader kind of guy. And it's always just kind of nice to put my 2 cents in just at the end after really you tell everybody what's going on. And so what I would say my 2 cents are on this issue is kind of to evade the question, what do you use to diagnose keratoconus? Really, what I use is other people. And by that I mean, as a cornea specialist, it is extremely rare for someone to come into my office seeking a diagnosis for what is going on. Almost always someone is referred to us because someone else has already figured out what the diagnosis is. I don't mean that to be purely glib. It's really, I think, actually important because the point is that if you are waiting for the keratoconus diagnosis to be made by the cornea specialist, you're waiting too long. The people who are making the diagnosis are the doctors out in the community. They're the people's regular doctor, the people that has seen everybody in that person's family for years and years and years. That's when the diagnosis has to be made, and not just a diagnosis in general. That's when the subtle diagnosis has to be made, because of course the idea with keratoconus is to treat the disease early. And so in order to catch the disease early, you have to be attuned to subtle findings in the cornea. The story that I like to tell in this regard is I had a very, very good friend in medical school. He and I were roommates in medical school and then intern year in residency. So we lived together forever. And he ended up going on to become a pathologist. And he told me that the way the pathology books are written are all wrong. And the reason the pathology books are all written wrong is because if you flip open the pathology textbook looking for something, what the pathology textbook tells you is it shows you a picture of whatever the cell is or the finding or the tissue, but it's the best picture that anyone's ever seen of that thing, and that's why it's in the book. And he says the reason that that's a problem is because when you're out there making the diagnosis, it doesn't look like the pathology textbook. And the whole reason that the picture's in the pathology textbook is because it's so atypical, because it's the best picture ever and someone put it in the book and repeats it ad infinitum because it usually doesn't look like that. So his point was in order to make the diagnosis, you cannot rely on the pathology textbook. And it's kind of the same way here with keratoconus. If you flip open the textbook to look at keratoconus, you see all these horrible cones and scarring and thinning. If you're making the diagnosis on the basis of those physical findings, you've waited too long. That's not what it should look like when you're making the diagnosis. So I would say, kind of to wrap up the point here, is that cornea specialists, ironically, don't end up diagnosing keratoconus that often. It's usually community doctors who are very smart and who are very attuned to these subtle abnormalities in the cornea who call me and tell me that there is a problem.
Yeah, that's awesome. That's a perfect kind of story to get us rolling. I think you and I would both agree that on the last slide, you know, topography and probably even more tomography is the gold standard, what we use in our practice. But our practice, similar to yours, we have a lot of these patients coming in either with a really high suspicion from their referring doctor or already a diagnosis from topography or tomography. for keratoconus or refractive surgery ectasia. This is kind of a nice overview here, topography, tomography. You know, really with tomography, we're adding a posterior elevation of the cornea, so we're getting information, data about both the front and back side of the cornea. Epithelial mapping, showing that the epithelium is really thinning over the area of cone and thickens directly around it. There's some new and exciting research coming with this. And then anterior segment OCT, giving us a detailed cross-section of the corneal shape, I think can be helpful as well. I really think, though, topography and tomography are the gold standard. That's what we definitely want to have. And then in some patients where we're having trouble making a definitive diagnosis, maybe epithelial mapping and anterior segment OCT come into play. But the question that I get asked a lot is, you know, topography and tomography is the gold standard, but according to market research that's been done, about 50%, maybe a little south of this number, of my optometric colleagues have a topography or a tomography in their primary care eye clinic. And so that begs the question then, can I do a good job of taking care of keratoconic patients? Can I diagnose and manage keratoconus if I don't have a topography or a tomography? And I think the answer is a resounding yes. You can still do an excellent job for these patients using some of the tools that we all have in our exam lanes. First, with the 4-opter. You know, optometry, we spend a lot of time working with the patient's glasses prescription. Any patient who's unhappy with their glasses is having big increases in myopia or astigmatism, really that half diopter and 1 diopter. This is from the clinical trials. And then a patient who's just not correctable to 20/20. Remember just to use the clues in front of you. It's not that common to see 4 diopters of cylinder in a glasses prescription. That should be a red flag. Patients who aren't correctable to 20/20, we really want to not forget about the cornea here and make sure that everything looks normal. Second, retinoscopy, getting out a retinoscope, bringing that light beam back and forth across the pupillary reflex, looking for distorted Meyers and that scissor reflex that we've all read about, but is still kind of evading us and is really difficult to find. There's a great study recently out of the journal Cornea that looked at retinoscopy compared to what we would consider the gold standard of diagnosing keratoconus, being pentacam tomography. And the sensitivity and specificity was approaching the 90th percentile for catching the disease. And then it was catching it correctly about 80% of the time. And so retinoscopy can be a really helpful tool for some of these patients. An autorefractor or an auto K, anytime you have an error message, this should be raising the red flags for you. And then manual keratometry, getting out that big drum and light, seems almost archaic now, but getting that out and looking for distorted Meyers, getting Ks can really be helpful here as well. In between each kind of question that's posed, I'll try to take questions from our audience. And so if people on the line have questions, don't be hesitant to put them kind of through as they come up. We don't have any right now, so we'll go right on to our second question. When is the right time to refer patients with progressive keratoconus or ectasia for cross-linking? What are some of the best practices for referring patients? And I'm going to kick that one to you again, Jack.
Well, you know, what I usually tell patients when they ask me about what are the benefits of cross-linking is I say it is basically a curative treatment for the progression of keratoconus. So it doesn't cure keratoconus, it cures the progression of keratoconus. It stops the progression of disease. It halts keratoconus where it is, more or less. And with that in mind, then, you can imagine how you would get the greatest benefit from cross-linking the corneas that are as near as normal as possible. And sort of the analogy that I use is that the cross-linking treatment is kind of like calling the fire department when your house is on fire. And you get the greatest benefit by calling the fire department when your house is kind of just maybe a little bit warm and there's a corner where you think that there might be some smoke. And you get a whole lot less benefit if the whole house is on fire by the time you get around to calling the fire department. So the idea is you want them there to put the flames out before you have catastrophic damage to the place where you live. And it's kind of the same way with cross-linking, is that if you have somebody that you are suspicious may have keratoconus, ironically, that's the person you want to be most aggressive about.
Yeah, that's a great segue here into the next slide, which is corneal cross-linking is FDA approved for progressive keratoconus and corneal ectasia. So how do we define that? And a commonly asked question that I get is, should I wait to see progression in my practice before I refer that patient out? And I think, again, this is an unequivocal answer of please refer those patients to us right away so that we can get baseline scans and so that we have data to use in the future to show progression or the lack thereof. This is a study here that's published in the Journal of Refractive Surgery, and it looks at delaying treatment for patients with progressive keratoconus. They delayed cross-linking either 2, 4, or 6 months, and they broke the patients up into basically 3 different cohorts: patients who are less than the age of 18, 18 to 26, and then patients who are greater than the age of 26. And the scatter plot to the right, basically what you can take away from this is young patients are going to progress more and at a faster rate. For patients who are less than the age of 18, they progressed in just 2 months, 1.1 diopters. And so for me, if my son or daughter is 15 years old, has definite tomographic keratoconus, we're going to cross-link that eye right away. We want to keep that eye from getting worse because the current state of cross-linking, we're trying to maintain what that patient has. And so I don't want to wait 12 months where we could lose best corrected visual acuity that we can't get back with cross-linking. And so cross-linking is approved for progressive disease, but really we want to get these patients in early. I think that's really important. Jack, what are some best practices? What do you wish that every cross-linking referral into your practice had?
Well, I think that this slide has got a lot of good information on it, and I think there are lots of different ways that question can be answered. I will say, just sort of in the way of a few general points, there are some people who are absolutely convinced that keratoconus cannot progress if the patients are not rubbing their eyes. I'm not sure if that's true or not, but there is definitely an association. And the very first thing that should be done for these people is to tell them to stop rubbing their eyes. That is an important question to ask patients specifically. Are you rubbing your eyes? And then secondarily, stop rubbing your eyes. I would say that you can elicit truthful answers to this question fairly readily by also asking about ancillary features to eye rubbing. Like, for example, if the patients have atopic disease or allergy or hay fever or seasonal allergies. Lots of these patients should, by the way, be seeing allergists. That is a very easy referral to make. The patients love going to see an allergist because it helps them with another major life problem that they have, which is also contributing to their bilateral blindness. So you really want to ask patients about that. I would say in the vein of, well, what about interaction with potentially referring doctors? I mean, what do we want from our referral cooperatives? And the real answer to that is we want any notes sent along with the patient or prior to the patient's visit, which document objective features about that patient's eye, like their refraction or their corneal parameters. Objective features about the refraction or the corneal parameters are necessary in order to document progression. Documenting progression is extremely important because everybody's insurance requires the documentation of progression. So if you don't want your patients to get in trouble with their insurance company, you can do them a huge favor by sending along notes that suggest objective parameters which can be compared to other objective parameters to document progression so the patient can have the treatment that their insurance is paying for.
Yeah, that's awesome. For our practice, I have the ancillary testing before I go into the patient's exam room. And so once I know that they have keratoconus, basically when I walk in, I introduce myself and then I ask, do you rub, touch, press on your eyes? And then I directly look at the person with them. And if it's their husband or wife or their spouse, boy, you're going to get a different answer than you get from the patient sitting in the chair. Finally, expectations. I think the referring doctor, being an optometrist or an ophthalmologist, has the first chance to set the stage, to set the expectations for corneal cross-linking, what the goals are. And so I think, of course, patient education is really important here too. Before we jump to our next set of questions, we're going to take some questions from the audience, and we have a couple here. This one is going to be answered later in our slides from Annie Lee about percentage of patients who have haze after cross-linking, and so I'm going to bypass that for now because we're going to have a slide and a good discussion on it. Second one is, I saw no slope in your scatter plot. Your conclusion doesn't seem to be supported. I basically just took a graph out of the paper. I'm happy to share the whole paper with you though, and slopes are above my level of expertise. Next one was regarding, we frequently see progressive ectasia in patients with PKs. Are they getting ectasia in their grafts? Hopefully they're not rubbing. Jack, do you want to take any shots at this?
We see ectatic PKs all the time. It is insane how you'll have a patient with a diagnosed history of keratoconus. They've got a PK in one eye and keratoconus in the other eye, and the PK graft is more ectatic than the other eye. It's something we see all the time, and who knows why it's occurring. I think that there are a couple of different theories. One theory is that keratoconus is a recurrent disease. You know, lots of the stromal dystrophies are believed to be recurrent. Granular lattice, macular stromal corneal dystrophy are believed to be recurrent in the graft. Maybe there are atypical pathological keratocytes which repopulate the donor graft and they make the graft ectatic. That's possible. I will say it's also possible that the interface between the donor and the recipient cornea is just extremely weak. We know the scar tissue that forms there is not good normal tissue. You can dehiss a PK graft 20 years after the surgery. It just peels right off. It never heals like a normal cornea would. The weakness at the interface may predispose the tissue to bulging there. That's possible. I don't know exactly what the mechanism is, but I certainly agree with the observation that PKs tend to become ectatic over time, particularly noticeable in keratoconic eyes. That's why we should try to avoid doing them. The whole point of cross-linking is to try to prevent an eye from progressing to the point where it has a PK, which is basically, in my idea, permanent ruination of the eye. A penetrating graft is not something I would want my dog to have, much less somebody I cared about. So I think that you really don't want to get to that point. So hopefully that's what this treatment will be effective at reducing the number of PKs performed for keratoconus.
Strong affinity for penetrating keratoplasty. Jack, check. We have a question that we're going to answer coming up here, but it's a really important one, and so I'll just reiterate it now. What values do you use to document progression? We're going to have a couple whole slides on this, but the big ones from insurance companies are an increase in myopia greater than a half diopter, an increase in astigmatism greater than 1 diopter, a change in the back radius of curvature on a hard contact lens, and then steepest K increasing by 1 diopter. And we'll have that coming up again here. So let's go to our next question. What is FDA-approved cross-linking and who is eligible? And I'll have you start again, Jack.
Well, people act as though this is a mystery about who counts as progressing for keratoconus. And I would say that in a sense, it's a mystery. There really are diagnostic dilemmas about a patient and you're not sure if they're progressing or not, and you really don't know, and you ask your friend and they don't know either, and you scratch your head and you think, okay, well, we'll watch and wait, and maybe we'll have some answer that's given to us by divine revelation. But that's not the relevant sense in which we're talking about progression here. What we're talking about progression here is what do insurance companies need to see for them to check that box and approve the procedure. The people who are reviewing the documents that you send are not ophthalmologists. They're not cornea specialists. They're not doctors of any sort. So they're people who just fill out forms. They probably don't know what astigmatism means. They don't know anything about keratoconus. They can't pronounce keratoconus. So you don't need to get into sophisticated scientific evaluations of, well, the front elevation or the back float. What the insurance companies are looking for are 4 things which the person who doesn't know what keratoconus is checks off on the sheet if it's there in the notes that you send to the insurance company. If it's on the sheet, it gets approved. If it's not on the sheet, it doesn't get approved. That's as simple as it is. What are the 4 things on the sheet? The 4 things on the sheet are Kmax by 1 diopter or more. Now you might say, well, over what time period? Well, we have this record from when the patient was 2, and here they are, they're 22, and the refraction is different, the Kmax is different. Does that count? Yes, that counts, because the only thing that the insurance company is looking for, the person who's looking at the sheet, is trying to determine whether they can check that box, and the box checking criteria are: number 1, increase of Kmax by 1 diopter over any time period; number 2, change in the base curvature of their contact lens; number 3, change in their spherical equivalent of 1 diopter or more; number 4, change in their refractive cylinder of half a diopter or more. So if you have any of those 4 things documented, it will be approved. If you don't have those 4 things documented, it will not be approved. And that goes for the patients who had a normal eye exam last year, and this year you look at them and they've got a Kmax of 80 and a thinnest point thickness of 200, and they're rubbing their eyes like crazy. If you cross-link that person, it will not be approved, because you have not documented that they have had a change in one of those 4 things, and the people at the insurance company are checking the box don't know what keratoconus is, and they will not be sympathetic to your remonstrations to the contrary. So if you can check the boxes, which are extremely predictable, you will get them approved every time. And if you don't check the box, you will be banging your head against the wall forever.
So the FDA clinical trials is really where these numbers came from. In April 2016, progressive keratoconus was approved by the FDA. Cross-linking became approved for these patients, and then second, corneal ectasia shortly after. And we've covered the 3 components that are really approved by the FDA. Another question that I get a lot is, what are contraindications? How do I decide who we can perform cross-linking on and who we should maybe wait? And these are all really relative contraindications, and I can make a case for any of them. I try to answer these questions on contraindications with, what would I do if it was my own eye? And so first, age. Age in the FDA clinical trial was 14 to 65. My general rule is, if we see progression in someone who is 60, I want to see it probably again to make sure that the scan is real, to make sure that that progression is real before we go forward with cross-linking. For me, if there's progression, really regardless of age, if it's 55 or 65, we're going to cross-link that patient, especially before cataract surgery. Second is a corneal scar. There's actually no contraindication or labeling against cross-linking patients with corneal scars. This is a common misconception. And so the rule that I use is, if we can put a specialty contact lens over this patient, most likely for me going to be a scleral contact lens, over this keratoconic eye with the scar, and we can get that patient to see well, then we should cross-link that eye so we can maintain the ability to see well in a specialty contact lens, because the alternative is Jack's going to do a penetrating keratoplasty and not be very happy. And that patient's still going to need a specialty contact lens. And so we're in the same spot that we are now. And then finally, a pachymetry less than 400 microns. This is not a preoperative pachymetry, but rather an intra-op pachymetry. During the cross-linking procedure, the cornea can start to dehydrate and thin. And this is where Photrexa comes in and trying to basically pump water or fluid in the cornea to get it to swell. And so there is no preoperative pack that says a patient's safe and going to have a good result from cross-linking. It's intraoperative, and the concern here is endothelial cells, which was something they excluded in the FDA clinical trial intraoperatively. We got a couple questions here. Let's see if we can take them. Do you have a corneal thickness threshold, which below you will not cross-link? We just took care of that one. I don't. Does a change in Kmax based on different tomography scanners qualify? For instance, if someone sends me a Galilea and I use a Pentacam, can it work? Jack, you want to take that one?
Absolutely, it qualifies. Now, it may not qualify to your own conscience in terms of actually understanding what's going on, because clearly from how you phrase the question, you recognize that, well, you get different information from different machines, but the person behind Blue Cross or whatever the insurance company, they're just looking to check the box. So I think that in terms of what you send the insurance company, it needs to be one of those 4 boxes. But I do agree that there are relevant things to consider in terms of the diagnosis of progressive keratoconus that are not in those 4 boxes. For example, you know, in order, the things that are supposedly most reliable for indicating real keratoconic progression are, in order, change in front corneal elevation, number 2, change in back corneal elevation, number 3, change in corneal thickness, and number 4, change in axial curvature. So change in front elevation, back elevation, thickness, those are all more important empirically, historically, than change in the curvature, but the insurance company doesn't care about that. What they want to know is, has number 4 changed, the curvature? So you should be paying attention to these other parameters in terms of taking good care of your patient. But the paperwork that you send the insurance company, it's very predictable. If you fill it out the way that they want it, it will get approved. And if you don't, it will not get approved.
How do you refer a patient that is not a previous patient, or you have a previous record for noting progression? Should I keep this patient and reevaluate in 6 to 12 months before referring? I'll handle this one. My opinion would be, if you are currently not in a surgical ODMD practice or a practice that has cross-linking, I think it's really helpful to get that patient into a practice that has corneal cross-linking, FDA-approved cross-linking, where they can start to lay the groundwork and the foundation of being able to cross-link that patient when insurance and finances and that patient choice dictates it.
Agree.
Let's jump forward here, and then we'll continue to take some questions. From a patient perspective, what can they expect with cross-linking on the day of the procedure and post-operative? And I'll have you lead again, Jack.
I think probably every practice in the country is different, and I think that's actually a very good thing. And what that means is that I think, consensus opinion on the results of cross-linking is attributable to the technology. You know, it's like if you go have cataract surgery, it's a very different result depending on who's doing your surgery. It's not that way with corneal cross-linking. And what that tells us is it's not the technician, it's not the physician, it's not whoever, it's the technology inherent in the modality. So in our office, the way it works is the patients just come to see us, not on a procedure day, not on a surgery day, just on a regular day. And they are just part of our regular clinic workflow for that day. We have a regular clinic room, and in the regular clinic room, we've got the cross-linking device, and we bring the patient in the middle of the regular day, and we do the procedure. And the way it works is that we anesthetize the eye with topical tetracaine. We use something to remove the central 9 millimeters of corneal epithelium. Some people use a little spatula. We use an alger brush just to polish the epithelium. Once that's done, we load the surface of the cornea with riboflavin for 30 minutes. That's just eye drops while the patient is leaning back in the chair. We have a technician sitting with them. They just give them eye drops every minute for 30 minutes. 30 minutes goes off. Then we give them 30 more minutes of eye drops, except they are also looking with their eye into the cross-linking laser. It's not some big laser pointer and, Dr. Evil looking thing. It's just this little light that they look at with this green target light. They look at it for half an hour while someone continues to give them eye drops every minute or so. And at the end of those 30 minutes, the procedure is over. So we do it all the time during our normal day, 5 or 6 a week. I did 2 yesterday just as part of my normal clinic day. And the patients go home after about an hour spent with us in the office total.
So it's very similar to how we do it. We do cross-linking blocks in our schedule. We're lucky to have a cornea fellow, so our cornea fellow does a lot of our cross-linkings. On the day of the procedure in our practice, a patient comes in, we've already counseled them, they know what to expect. They're going to get 5, maybe 10 milligrams of Valium just to relax them. A nurse preps the eye with a betadine wash. And then this is really what the procedure looks like. It's a long procedure. Start to finish, it's going to be at least an hour of active treatment, of getting the riboflavin drops and the ultraviolet light. We don't use a well of alcohol with our surgeons. We use kind of a blunt spatula here, removing the epithelium. It's an 8 to commonly 9 millimeter epithelial defect. Riboflavin drops get put on the eye. And ultraviolet light. That is a very young and non-gray John Berdahl doing that procedure there. And so afterwards, here's kind of the 4 main bullet points that I try to give patients for early postoperative expectations. First, we ask them to avoid rubbing, touching, pressing on their eyes. We've asked them to stop eye rubbing forever, and so they shouldn't do it right after the procedure. For the first 4 to 7 days, I tell patients it's going to be moderate discomfort, teary, scratchy, light-sensitive eyes. I tend to see this being worse in younger patients who have cross-linking. As we get older, we lose some of our corneal innervation, and so these patients who are a little bit older that we cross-link do well. I'll tell patients they can take whatever they take for a headache, so Tylenol, ibuprofen, aspirin to help ease the pain, lots and lots of artificial tears, and then keeping sunglasses on sometimes even in the house. Lubrication is really important for these patients too. A large increase in pain, redness, or swelling, these are kind of the signs for infection, and so we talk to patients about giving us a call right away. And then finally, the one that seems easiest to us, but maybe most difficult for patients, is if the contact lens falls out, please leave it out. Don't try to jam it back into your eye. You don't have to bring it to me in a sandwich baggie. And so those are some of the big things that we tell patients right afterwards, but I try to set the expectations really preoperatively so there's no surprises here. We had
patients often ask me, Mitch, when can they rub their eyes again after the procedure? That's the question that I get.
We had a couple of good questions come in here, so I'm going to give a couple to you, Jack, because it'll help me too. How would you work with a history of a patient who has HSK history, so herpes simplex, in moving forward with cross-linking? Anything you do different?
Carefully. That's never come up, but it's something I have thought of before. So what's the risk? What's the risk? Well, theoretically, solar radiation increases your risk of relapsing if you have HSV keratitis, right? There are certain environmental stressors which we hypothesize may lead to a recrudescence of the virus. So theoretically, you might get an outbreak of HSV keratitis if you cross-link somebody. That's the risk. I've never heard of that actually happening, even though I understand the theoretical risk. If we don't cross-link somebody who is definitely progressing, if they have progressive keratoconus and we don't cross-link them, they will definitely lose vision. That's one point. I think that other people do have recurrent HSV. We have lots of people in our practice who have recurrent HSV. It's a bad disease. I certainly wouldn't want it myself. I feel sorry for the patients that I have that I take care of, but I think I would rather risk an extra HSV outbreak than not get cross-linked if I needed it. That's the way I personally think about it. I don't know there's any evidence to support it, but if it was my eye and I had progressive keratoconus and there was a risk that I would have another HSV outbreak, I would definitely take that risk.
Yeah, I kind of still use a rule that I learned in residency from some of the my mentors in ophthalmology. There was, we just put those patients on antivirals. We treat them for at least 2 weeks before the procedure, and then we treat them for at least 6 months afterwards. And I think your point is very good about, there's a chance that they do have a reoccurrence, but there is a bigger chance that if we don't cross-link the eye, it's going to progress, and we can come back from a viral infection. We have lots of good medications there. It's much harder to come back if we have a steepening cone and especially scarring. One more, and I'll answer what we do in our practice, and then Jack, I'll kind of let you take a swing at it. One is, do you do bilateral cross-linking? So cross-linking right eye, left eye on the same day. In our practice, we don't, except for patients who maybe have cognitive concerns. Some of our Down syndrome patients, we will do bilateral cross-linking on. The reason for 98% of the time we do one eye at a time is because when the epithelium is removed, of course, the vision is going to get worse. The vision after cross-linking for the first 7 days for sure, maybe out to 4 weeks, is going to be worse than it was before their preoperative baseline. And so we don't want to take away vision in both eyes, especially some of these patients wearing specialty contact lenses.
Agreed.
Great. I love your succinctness there.
There's one more question, by the way, that I think can be answered quickly. Have you combined cross-linking and intacs? In what order? Yes, we do it all the time. We've done it in both orders. It doesn't seem to matter in our hands. And there are published reports that show that the sequence doesn't matter. If you cross-link them first versus if you cross-link them second, they have the same topographic and visual result. Surprisingly, but that's what the data show.
I'll weigh in on that a little bit too. We do cross-linking and intacs as a procedure that works together very commonly in our practice, probably 30 to 40% of the time. We mostly use intacs for patients who either can't tolerate a specialty contact lens or who have best corrected glasses vision of worse than 20/40. That's just kind of the rules that we use. We've done it all 3 ways. So same day doing cross-linking and intacs. This is really difficult to get insurance coverage on in our area, so we've went away from that. Second, we've done intacs first. This is actually how we started doing these procedures as a team. We would do the intacs first. We found that in our surgeons' hands, it was a little bit more difficult to get the intacs into kind of a biomechanically unstable or weak cornea. And then you come back and freeze the cornea into place later, as well as insurance in our area is difficult with that. And so now most commonly we'll do cross-linking and intacs about 4 weeks later. So more of a sequential treatment, which we've had very good luck with. Let's jump to our next one from a practice, MD-OD kind of administrator perspective. How does cross-linking fit? What is the workflow? Who's doing the counseling, the cost, the reimbursement? And I'll tee it off with you, Jack. I know there's some hesitancy in, this is an hour-long procedure. How am I going to fit this into my day? I'm a busy surgeon, and I'll let you kind of speak to that.
Yeah, it's actually extremely easy. There's, you know, there are problems that you have and you think about them and how are we going to solve this, and you just have to go try it. And when you try it, you realize it's actually not a problem. And the reason it's not a problem is that, yes, the procedure takes an hour. I'm in the room for about 60 seconds. And the reason I'm in the room for about 60 seconds is I remove the epithelium from the cornea. And once we the location's eye, I put the first drop of Photrexa in. Everything else is done by the technician. And what is contained in everything else is just giving eye drops. It's basically just eye drops for an hour. So we have a technician sit in the office and give eye drops.
I think that makes a lot of sense here. That's very similar to how we do it in our practice as well. We have our surgeon come in, remove the epithelium, give the first drop of ceremonious riboflavin, and then we move forward from there. Another big question that comes up and is an important one to answer is, how is this covered for our patients? What's reimbursement like? And I can kind of take a first stab at this. The corneal cross-linking reimbursement is miles and miles better than it was in 2006 when we first started working through this. This has definitely improved. This is a heat map provided by Glaukos. This is about a year old now, so it's even going to be warmer than it is now, but you can see how hot South Dakota is there with an 8. Now, over 95% of commercially insured patients, so non-Medicare, non-Medicaid, have some reimbursement for corneal cross-linking. And Glaukos is, of course, shooting for that 100%, but this is much, much better than it was when we first started this right after the FDA clinical trials and commercial availability. I do want to add a point to patients who are underserved, whether they be non-insured patients or patients who are on Medicaid, can't afford the financial dollars to have cross-linking. Glaukos does have the ARCH program, which is a program where they will donate the drug. And then there are practices across the country who will donate the surgical time, and patients can get cross-linking at basically pro bono or no cost. I know this is something that you utilize in your practice, Jack, if you want to add anything here.
Not much. I agree completely. We do about at least 10 to 20% of our cross-linking for free. The company, Avedro Glaukos, they donate all the solution to us that we need. So if we have somebody who doesn't have insurance or can't pay or has crummy insurance, it's no problem. We cross-link them for free.
Yeah. I alluded to this early, but this is a sheet that we have in every new keratoconic eval chart that comes into our practice. We're still working on paper charts. We're switching to electronic health records soon, and I imagine we'll have some variant of this in the charts, but this is something that we have so that the optometrist or ophthalmologist can really go down and check these boxes to do everything that we can to make sure that we've done the correct steps for insurance to get this covered for our patients. The final one at the bottom here, failed conservative treatment, being spectacle correction or rigid contact lenses, that includes soft lenses as well, has been a box that we can check as kind of a fallback for some of these patients and has worked well. And so important to know kind of your different state insurers and how this works, but that's been one that's helped for us too, in combination with the ones that you see above here. So Jack, I'm going to throw this one to you. What are some of the key learnings that you've had for follow-up care or the co-management of cross-linking patients? I know you're doing this heavily with your referral network. What are some of the tips and pearls that you have?
Well, I think that there are a couple things. So the first is that really cross-linking is still performed few and far between places now. I think we're one of the only places in Alabama. There are a few other doctors here doing it, but on a much lower level. And so the bottom line is that you're going to have patients sent to you, and you're going to be sending patients far away, far away. And I don't think there's anybody cross-linking. For example, in the state of Mississippi, I might be wrong, but there are states in the United States where you can't get cross-linked. So the reason I mention this is that if patients are going to be traveling a long distance, it's very important that they have an efficient process, which is to say, what you'd like to have done is have the patient show up to you, see you. When they come to visit you, or when you send them, they go with paperwork that documents that they have progression, or at least it documents their baseline so they can be checked at that visit with the specialist for progression. And if they are confirmed to have progression at that visit, they can be treated at that visit and go back home permanently to the referring doctor. It's kind of like how some people do cataract surgery and, you know, have all the follow-up care with their referring doctor. It's very much the same way with cross-linking, except it can be more important because there are cataract surgeons in Mississippi, but there are no cross-linkers in Mississippi. So if patients are traveling long distances, it's very important that they be able to go somewhere, get efficient, potentially one-time, same-day treatment, and go back home and do all the follow-up care with the referring doctor. So we've all got to be on the same page to handle the handoff so the ball doesn't get dropped. So it's very important that we all have each other's cell phone number and talk to each other and are communicating, because the patients come right back after the treatment.
Yeah, collaboration is huge here. It's really key. A couple pertinent points here. Post-operative management is really similar to PRK. So if you can raise your hand and say, I've managed a patient post-PRK, you can now manage a patient post-cross-linking. It's really managing a large epithelial defect that the surgeon is purposefully creating in the beginning, removing a bandaged contact lens, and then setting expectations. New optical correction there at the bottom. These are kind of cookbook rules. We deviate from these in our practice very commonly. And I try to remember that sometimes the specialty contact lens is really a lifeline for the patient. Without it, they can't drive or sometimes go to work. And so I'm happy to fit them in a new scleral sooner if needed. We use a combination of antibiotic and steroid in our practice. There was a question that came through about post-operative pain medication. We will use Acuvale or an NSAID. We give them a couple vials, and hopefully they shouldn't have to do this after the first 3 days. A really important key with cross-linking follow-up care is, unlike cataract surgery, which Jack referenced, where we have a post-operative global period, 90 days, where you're billing all of those visits under a post-op visit, cross-linking does not have a global period. And so you want to bill office visits for these patients. You bill them as office visits back to their insurance. At the 1 month post-op, really, this is when we're starting to see some corneal haze. This is very common. We had a question come in the chat about how often do you see corneal haze? Almost 80 to 90% of the time, I think of corneal haze being a positive thing. This tells me that something is changing in the cornea. We have a reaction going. We have new bonds or crosslinks being formed. And the key with corneal haze is really that it's almost exclusively thought to be non-visually significant for our patient. This is some work that Peter Hirsch's group did on corneal haze after cross-linking. I very commonly will see this at the 1 month. It's lessening at the 3 month visit. and then gone by 6 and 12 months. In the FDA clinical trial, less than 2% of patients had persistent corneal haze that was visually significant. And so this is very low overall. This is when we're fitting that new specialty contact lens, scleral synergize or a hybrid lens. Really, that is what we're trying to get to. We all know that the corneal shape is often changing in this time. And so if we go sooner than that time point, or even at the 3-month time point, we may need to be tweaking that contact lens a little bit here. I'm going to take one question, and then for the sake of time, we'll keep rolling here. Early minor steepening can be safely observed for how long? When would you consider repeat cross-linking? I'm going to jump on this one right away. The epithelium is going to remodel. So very commonly after cross-linking at the 1 month or even sometimes at the 3-month visit, it will look like the topography or tomography is worse. It looks like it's steeper than it was before, and this is because of epithelial remodeling. I put most of my chips in a 9 or 12-month post-op visit, and so in our practice, we are co-managing cross-linking 90% of the time or so, and we're having that patient back usually about a year after their procedure to just follow up on the tomography. Anything to add there, Jack?
No, perfect.
All right. Jack, next question to you is, what do you want every optometrist to know about managing keratoconus and refractive surgery ectasia patients?
Well, I would say there are two things. The first is it's critically important to know how to diagnose keratoconus, particularly in its early stages. You cannot rely on the specialist. You cannot rely on somebody else. You really got to figure it out while the patients look basically normal and have virtually no complaints. That's the time where the cure can be best applied. So you should have this diagnosis in the back of your mind. You should be thinking about it, and you should be willing to refer patients when you're not sure because of the possibility that they may have a curable progressive disease. That's the first thing. And the second thing that's important to know, other than just how to diagnose early keratoconus, is your go-to person, your referral buddy to send these patients to. Somebody that can see the patient in a timely way and refer the patient back to you in a timely way, so the patient can go get the curative treatment and then come back for all of their regular eye care for the rest of their life.
Yeah, I totally agree. I don't have anything to add there. As a practice trying to grow a cross-linking program, how do you engage a referral network? I think both of our practices have done this nicely, and so I'll take a first shot at this one and then pass to you, Jack. I think it's really, really important to pose this question with a short answer of collaboration is really key here. On the left, this is a Venn diagram of sorts on cross-linking volumes being done in our practice at Vance Thompson Vision, and really the majority here, about 70% or a little greater, is going to be optometric referrals. So the optometrist refers this patient to us, we take care of the cross-linking and get them back to that provider. We do have some referrals from general ophthalmologists in our area who don't have FDA-approved corneal cross-linking technology in their practice. Less and less we're having newly diagnosed keratoconus at the time of a refractive surgery exam. So a patient who said, boy, I'd like to have LASIK or PRK, and they turned out to be ectatic. And then a patient who's previously diagnosed but didn't have the means, or it was pre-cross-linking FDA approval. We still have maybe 5% of those patients trickling in. But it's a huge bullet point here at the end is we want to build a referral network because many of these keratoconus patients are starting and then again finishing in optometric practices. I think step number one is to communicate to the optometrists and ophthalmologists in your area as you're bringing this onto your practice of, hey, we have FDA approved cross-linking technology. We're here to collaborate with you and take care of these patients. And so if we said step number one was to market this to your referral network, that you have the FDA approved technology. Next is understanding what I believe optometrists are really wanting out of keratoconus patients and kind of the referral that they make. First is continuity of care. Frankly, I think ODs want to get their patients back. They want to take care of these patients and continue that relationship that they have. Secondly, the optical correction. This is the lifeline for a lot of optometric practices. And so after cross-linking new glasses, soft contacts, a lot of optometrists are very, very good at fitting specialty contact lenses for these patients. So it can be a revenue source as well as an interest that they have. Next, I think optometry's goal is they want to know, is it covered by insurance? And so communicating insurance coverage, progression, those are all important things. And then finally, did it work? I think a ball or pitch that we want to swing at and make sure that we hit is letting our referring network know that, hey, we were able to stop the progression of keratoconus or refractive surgery ectasia in your patient. Since cross-linking is usually not a procedure where patients go from uncorrected visual acuity, that's 20/40, to now uncorrected 20/20, this isn't a refractive procedure. We have to be able to show the merits and the success. And I think that follow-up pentacam at 9 to 12 months is important for these patients. After cross-linking, how do we do the handoff? How do we collaborate as a team? Remember, there is no global period. So if you're educating your referral network, it's important to let them know to bill office visits. In our practice, similar to what Jack said earlier, is these patients are heavily managed by the referring doctor, whether that be optometrist or ophthalmologist. They're really coming into our practice for cross-linking and then again about a year later. And so the follow-up care, everyone has a little bit different cookbook or schedule that they're going to use. For the optical correction, we showed some different dates there. Those are kind of timelines that you can loosely use, but getting patients back to their best vision. Really, step number 1 is to cross-link these eyes, and then step number 2 is to rehabilitate the vision. Long-term monitoring, cross-linking is very, very effective. I tell patients in our practice, from my experience in the FDA clinical trials, about 95% of patients have halting of progression or they don't get worse. But this is still a condition that has the potential to worsen. And so we can't just forget about these patients. Here is a loose word for cross-linking, and I think we still want to follow them up. And then finally is familial education. We want to let the family of these patients know that there is a weak genetic component to keratoconus, and this is a good time to get family members screened. I'm excited for some of your inputs here, Jack.
I agree with everything you've said.
Beautiful. Well, let's close up with this. Thank you to Glaukos again. Thank you to OCCRS and all of you who came on to this call tonight. We appreciate you being here. Your attention and your questions were really fantastic. Before I forget, I do want to invite any optometrists who are needing continuing education credits and are interested in keratoconus and cross-linking as a whole. Sunday, June 14th, Dr. Gloria Chu from USC will be giving a lecture on keratoconus, kind of the management of keratoconus as a whole, in collaboration with Evolve. Evolve will also have Dr. Blumenstein and Dr. DeVries doing some education, so there's 3 hours of COPE-approved education on this Sunday morning. And if you're interested, www.evolvemed.com, evolvemeded.com. Thanks again so much to Jack and our partners here, and we look forward to connecting with all of you soon at meetings that are hopefully in person again.
All right, thank you very much, Dr. Ibach, and thank you, Dr. Parker, as well. From Glaukos and OCCRS, we'd like to extend our sincere appreciation to today's exceptional speakers. Thank you also to attendees for joining us for this informative discussion. In follow-up, you will be receiving a link to today's recorded webinar in the coming week, as well as the PubMed links for the articles cited in this presentation. You will also have the opportunity to reply to a quick survey. We thank you in advance for your responses. Thanks again.